Thanks, Meredith. Thanks for having me, first of all. I appreciate the opportunity to come over and speak just a little bit about some of our research that we're involved with. Meredith has come a long way since her residency days, which was that 4 years ago, 5 years ago?
5 years ago.
5 years ago, yeah, I can't believe it. So she's done really well, and we're excited to see what she's doing. So today, what I'm going to do is share with you guys just a little bit about some of our clinical research that we have ongoing with Texas Health Sports Medicine, and specifically looking at our ACL population. So those individuals who have torn their ACL and how they fit into our system across that continuum of care, right? So think about it hopefully just a little bit differently. Oftentimes you'll hear individuals that have torn their ACL that the big thing is when they go back to return to sport, what do they look like? Are they able to go back to their sport? Do they have long-term consequences of like joint arthritis later on down the road? We have a pretty specific little niche with our program where we can look at someone by the time that they've, at the time of injury, right? So they've torn their ACL, and then we get different time points along that continuum of care, really from pre-op all the way to the time that they go back to sport. So we'll talk a little bit about that, and more importantly, I think, is how we use our data, not just to publish papers and do presentations, but how we use it to make clinical decisions. So things that we find out at pre-operative or at 12 weeks or return to sport, we use that to change the way we practice as well. So as a little bit of a kind of an overview, I am with Texas Health Sports Medicine, which is the system service line for Texas Health Resources. We are sports medicine service line. My job has kind of transitioned over the past couple of years. So I kind of serve as our director of sports medicine research across the system, which includes a large team. We really have four main focuses. We have a lower extremity focus that really is ACLs. We have an upper extremity focus, which, like Meredith said, is looking at overhead athletes and UCL and shoulder injuries, throwing athletes. And then we have a sport-related head trauma that I'm involved with as well, that kind of help to manage that and looking at those individuals who have had concussions. And then our newest kind of pillar, it kind of comes along with one of our surgeons that we just recruited from Pittsburgh, that is athletic hip. And so looking at hip outcomes and hip biomechanical studies. So we have several labs, upper extremity, lower extremity labs, and more that we're building across the system. And so my job is to work with our physicians, our athletic trainers, our physical therapists, and the rest of our staff to create a research agenda. So as part of that, specifically for this talk, we're looking at our ACL population. And so as part of that, since we started back in 2015 with some of our biomechanical labs, what we have done is we've been very fortunate to test over 300 ACLs in our lab, meaning that they've come in for different time points, and we've got repeated time points on those individuals, looking at what they look like biomechanically, muscularly, all these different things. And we also have, this is probably closer to 400 now, healthy controls that will run through our lab as well. So now we have some normative data with the ideas that we're trying to build some normative tables to say this is what an individual looks like when they're healthy, so we can compare them to the injured population. And so our adolescent population is an average age of about 15 and a half. And so that's the majority of ACL injuries that we see is right about that 15 and a half age. And our sports include soccer, basketball, volleyball, football in that order, right? So it kind of makes sense what you would typically think of. Now, we do have, we're fortunate to have a very nice research team that includes biomechanists, some clinicians, and then our physicians, and that's really what helps to drive this. And so essentially what happens is if one of our physicians that's on our ACL research team, if they are getting ready to do a surgery, an ACL surgery, then before they'll actually even do that surgery, then they will send their patient to our lab, and we actually will enroll them a study, and then we follow them throughout that from preoperative to time of return to sport. So and we have a group of research coordinators, and also our residents are heavily involved in that as well. So now, what I want to talk about, like I said, is just kind of how we've developed this clinical pathway for treating the ACL, not just at one time point, but across the continuum of care, and how we use that data, really incorporate those research findings into our clinical practice. So the way it works is that someone gets injured, and let's say that little Susie is 17 years old, she tears her ACL, and one of our physicians is going to do the surgery. So preoperatively, before she has surgery, then she'll be enrolled in the study. We test them preoperatively at 4 weeks, 12 weeks, 4 weeks, 8 weeks, 12 weeks, 4.5 months, and then time to return to sport. For this particular talk, though, I'm going to focus on preoperative, 12-week, and then time to return assessment. just to say, what does the data say? What are we seeing clinically? And then how do we apply those research findings to our overall clinical pathway? And then what we'll look at as well, some of our ongoing projects that we've learned over the past couple years to say, this is what we know, and now we're moving in a different direction, or we're furthering our study with some of this ACL. So if we just kind of get a timeline, what we're looking at is at time of injury, and the average time of injury that we see these individuals, they tear their ACL. On average, they will have surgery within our system of about 23 and a half days. So time of injury, 23 and a half days later, they're having surgery. And so what happens then is that we start to look at them preoperatively. Again, we look at them 4 weeks as well, but we're not focusing on this. We're not focusing on the 4 weeks and 8 weeks. Then we'll look at the 12-week, and then again at that time of return to sport, and see what their clinical profile really looks like. So we start off, and the three main focuses we'll talk about is strength, because that's really important. So we want to know, what is their quadricep strength at this pre-op, 12, and then return to sport. We'll look at their balance or neuromuscular control. And then we also look at what we call just loading biomechanically. How well are they loading? Are they loading symmetrically? Are they doing different things within their limbs? Are they unloading? And so those are the big things. We also look at range of motion. We look at swelling. We look at patient-reported outcomes. So all these different things. But the main focus that I'm going to report today is, what do they look like from a strength standpoint, neuromuscular control standpoint, and then an overall loading or biomechanically. And so if we look in the literature at just preoperative quad strength, there's not a ton of data out there, but what we know is that preoperatively we see some deficits that are already present at time of injury, meaning these individuals, think about them, they have been healthy, they have torn their ACL, but now within a month, now they have quadricep strength deficits. Now, the question is, did they have those prior to the injury? Possibly, and that may have contributed. We don't know that for sure, but the literature shows that there's a 17% quadriceps deficit and a 19% quadricep deficit. This is the literature that's 2007, 2009. If you look at our data that we published just recently, 2017, two different studies that we have, is that we see about a 30% quad deficit at preoperative, meaning that my injured knee is my right side, uninjured is my left side. I've got a 30% deficit preoperatively, and again, 23 and a half days on average from time of injury to the time that they actually go and have surgery. So we're already seeing deficits to begin with. We also have a paper that just came out last year that actually looks, what about the uninvolved side? So not the injured side, but the side that was not injured. What we see with that is that within those 23 and a half days, we're starting to see some deficits that take place in the uninvolved side. So now we've got deficits in the involved or the injured limb, but also the uninvolved side, which nothing happened to that. So that hints at there's some type of neural component that's going on that we'll talk a little bit more about. So it's kind of a little bit concerning to say we've got quadriceps deficits on the involved side, but also on the uninvolved side. So we have to keep that in mind. Now, what about a big focus right now on ACL rehab is the hip and the hip strength. So if we look at our data that was published last year, if you look at hip external rotators, abductors, and extensors, there's no significant difference in quad strength when they're compared to a matched healthy control, right? So we see quad deficits, but not necessarily more proximally at the hip. So is there this peripheral central deactivation of the quadriceps that is taking place, but not necessarily at the proximal hip musculature, right? So we keep that in our mind. We've got quad deficits involved in uninvolved side, but not necessarily at the hip. Now, what about balance? One of the things, or neuromuscular control, that we look at is this lower extremity wide balance. And what we see is that at the time of injury, preoperatively, before they've had surgery, is that we see within limb differences, meaning that the balance on the injured or involved limb is decreased compared to the uninvolved limb, which kind of makes sense. Now, if we look at the involved and uninvolved when it's compared to a matched healthy control limb, right, we also see differences on the uninvolved side. So involved side, significantly different compared to the matched limb. Uninvolved side, again, differences, meaning that there's deficits in balance on the uninvolved limb. So we said the uninvolved limb has deficits in quad strength and also deficits in balance. So we're off to a really good start, right? So we've got quad strength deficits and balance before we even have surgery. So we see these bilateral deficits in the neuromuscular control that are present after ACL injury. Now, if you look in the other literature just in the gait, so that's a particular task that we look at. We look at squatting, we look at gait. I'm not presenting our gait data today. I'm presenting more of our squats and our more jump landing and cutting type activities. But if you look in the other literature, in ACL literature, in someone who has injured their ACL at that time of injury, what we see is they change their patterns of the way they walk. So they get decreased knee flexion angles, so they don't bend their knee as much. They have decreased knee extension moments, meaning that they're not loading that injured limb quite as well. That's when it's compared to the uninvolved limb as well as to a matched healthy control limb as well. So we see these loading deficits that take place. Now, one of the big tasks that we do, a very simple task, is just a squat, a double limb squat. So at the time of injury, what we do is we look at them and we want to see how well are they loading their limb, their involved limb and their uninvolved limb. So they're injured versus they're uninjured. And what we look for, and this is just a little screenshot that we actually give to our physicians and to our physical therapists that are working with these patients to say, how well are they loading from a limb symmetry index, involved to uninvolved? And we're looking for a target symmetry index, meaning that we're putting equal weight through the limb. We're looking for a target of about 0.9 to 1.1, so somewhere that we're getting equal symmetry through loading there, right? Now, keep this in the back of your mind. So this particular female, we'll use it as an example because she mimics kind of what we see with our research. So preoperatively, what we see in their loading is she's about a 0.85, so pretty good from a symmetry loading standpoint, right? However, this can really be misleading because if you just look at her and you look at her ground reaction forces, it looks like she's loading symmetrically. What's interesting though is she's using a different strategy between her limbs to do that. So what we see with this, that individual, remember the ground reaction forces looked pretty symmetrical. What we see with this is they use a different contribution within their injured limb. So that ACL limb, what they do is they pick up and they use more of a hip contribution. So when we look at this, we look at something called energy absorption contribution. And essentially, energy absorption, we're looking at this negative area under the power curve, right? And so think about it from a clinical standpoint. We're looking at how well they can eccentrically control their descension when they squat, okay? What we see is that these individuals that have had preoperatively ACL injuries, they use a greater hip contribution. So what you'll see is they have greater hip on the involved side contribution compared to the uninvolved side, but then a lesser knee contribution. So they unload their knee and they use more hip, all right? Now with that, what we also see is it goes hand in hand with their quad strength deficits. So we see decreases in their quadriceps strength on their involved or injured side as compared to their uninvolved side, okay? So we see these early asymmetrical loading strength deficits. Now, that's in a double limb squat, right? So 2 legs squatting down. Now, if we look at a single limb squat, this graph makes it look like there's actually differences in the total energy absorption, so how well they absorb involved side to the uninvolved side. There's actually no significant differences in this particular one when you look at the total energy across injured limb versus uninjured limb. What's interesting though is if you look within that limb, hip, knee, and ankle, you start to see changes. So now we go back to that same pattern. On the involved side compared to the uninvolved, those injured individuals use greater hip contribution than the uninvolved side, okay? Same thing at the knee. At the knee, they use less knee contribution than the uninvolved side, okay? So greater hip contribution, less knee contribution, and it goes hand in hand with what we see with our strength deficits, okay? So preoperatively, what do we take away? Well, we take away, number one, is that they have this involved quadriceps strength deficits. Their strength has gone down on their injured limb. They also have uninvolved quadriceps strength deficits. And then within limb and between group, Y balance test lower quarter differences, meaning that their balance is decreased both on their injured limb and uninjured limb, okay? Then we look at deficits in loading. From a loading standpoint, gait, stairs, double limb squat, single limb squat, they alter the way they're actually moving and loading through their joints. So the total energy absorption may be similar between the limbs, but if you break it down and look at the hip, knee, and ankle, you see a greater hip contribution with a lesser knee contribution. Now you might say, well, that's great, but what does that mean? Well, now all of our therapists and our physicians are getting this information to say, I've got little Susie who's coming in and I know that she has these particular deficits, so I can begin working on those right away. Right? So that is before surgery. Yes?
I just asked a question. I know you said pre-op, I think 4 weeks period.
Yeah, so time of injury, they have an injury within 23 and a half days. is the time that they typically have surgery. So we're testing them within 2 to 3 days of their surgery.
Okay, so is that, so I guess if you took someone like 5 days after their injury versus 20 days?
Yeah, typically they won't look as good. And so what we try and do is we try and stabilize the knee.
Okay.
So when they've got all that swelling, they can't put weight on it, they can't bend it, straighten it. They have to normalize their swelling within a couple of centimeters. They have to normalize their range of motion. And then at that time, when they can create and they can walk without crutches and stuff, then we test them.
So they basically adapted to some extent.
Correct.
To the injury.
Absolutely, yeah. What we did is when we started piloting all this, and we would just test them right away, I mean, the data is just all over the place. So we kind of normalized it to say, and that's a surgical, clinical thing that we look at as well. Our surgeons are not going to do surgery until the knee is kind of stabilized, if you will. Yep, good question. So with that preoperative, then this is what our physicians and our clinical team will actually get, is they'll get this information to say, okay, this is little Susie, and this is what she looks like. This is what her quad strength is, this is what her hamstring strength is, and then this is what she looks like loading. So now we have this clinical profile in this picture to say, okay, this is my patient coming in, this is what I know that they're capable of doing, and these are the deficits that they have, so let's start to work on those. Okay? Again, remember when we said this, preoperatively, their symmetry index looks pretty good. They can load equally through both limbs. Okay? Now, the next thing we go to is that 12-week. In between, like I said, we're assessing 4 weeks and 8 weeks. I'm just not presenting that particular data today. So at 12 weeks, quadriceps strength assessment, if we look at the literature, previous literature, the earliest that is shown for quad strength deficits that have been studied in the literature is right about that 2-month mark. And what we see is when they're tested at 30 degrees and then also at 90 degrees with isometric quadriceps strength, there's a 67 and a 56% deficit in quads. So involved side compared to the uninvolved side. All right? So we already see strength deficits at 2 months. Now, in our data in the paper that just came out this summer, what we see is that if we look at quadriceps strength, and this is tested isokinetically, so it's 60 degrees per second, isokinetic. If we look at the involved quadriceps strength, it is decreased compared to a matched limb of a healthy control. So decreased quadriceps strength on the involved limb, no differences in the uninvolved limb. And remember, preoperatively, we saw deficits on both sides, but at that 12-week mark, what we're starting to see really hasn't changed much for the involved limb. However, the uninvolved limb is now normalized to a healthy control. And one of the points that I will make with this is that there's some limitations with actually saying that our standard or our gold standard for testing our injured limb to our uninjured limb is because that uninjured limb is going to have some changes that take place. So we've really moved to more of a normative database to say these are our norms for somebody that's healthy, that's 15 years old and plays soccer and that's a female. We've moved to matched healthy limbs as a comparison. It's a better picture of what they're actually doing. Okay. Now, the other thing we said is that at 12 weeks post-operative, what we see is that these individuals who had deficits, they still have those deficits on their involved or injured limb at 12 weeks, so the same ones they had pre-op. But what's concerning is that we see a 17% decrease in quadriceps strength from pre-op to 12 weeks. And you say, well, why is that concerning? Well, they have been through at least 12 weeks of formal physical therapy, at least on average 2 times a week. And so now, not only have they not gotten stronger, but they've gotten weaker since the beginning, right? So again, we used to think we were really good with our rehab, and we realized the more we study, we're not very good, right? So other things we look at from the strength standpoint, this is a study that one of our athletic training residents from last year is involved in and finishing up her paper now, is that if we look at this ratio between hip strength, which we think is really important for ACLs, and we look at that in a ratio to the quadriceps strength, we see that there's this relationship between a hip strength ratio to quadriceps strength. So that ratio, what we see is that it is related to what happens at that 12-week time point, right? And so when we look at this, in this particular study, we looked at joint moments and net power at during a single limb squat at return to sport. So we were trying to predict if I've got a good ratio of strength, hip strength to quadriceps strength at 12 weeks, does it predict what I'm going to look at time of return to sport? And what we actually see is that this ratio of hip abduction to quadriceps strength ratio at 12 weeks actually is related to the knee extension moment during a single limb squat as well as the energy absorption of the knee at return to sport, right? What this means is, as my quadriceps strength is lower and my hip strength is higher, that ratio goes up. We see that ratio is equal to deficits in the single limb squat at return to sport. Meaning if my quad strength is not good at that 12 weeks, like we already said, it's going to predict or is related to the fact that their single limb squat is going to be impaired at time of return to sport. So 12 weeks to time of return to sport. So again, something we can use clinically. It hits back to that same thing, is that quadriceps strength is deficits. I've got to hit that even at 12 weeks. Now, one of the questions with this is, why are we seeing these strength deficits? There's a lot of different factors that have to come into play here, but if you look at just the kind of muscle physiology standpoint that a lot of you in this room probably know much better than I do, but if you look at this from an ACL injury standpoint, it's associated with the quadriceps ability to kind of regenerate and gain strength. So we see this increased extracellular matrix, we see decreased satellite cells, and so we look at that and say, with the ACL injury, we know that something's going on physiologically as well. How do we address that? How do we provide enough of a load to stimulate that muscle, not only mechanically, but also neurally, to get that muscle to start firing like it needs to? Zargi actually did a study in 2016 that's really interesting, that's given us some insight into this quadriceps strength. And basically what they found is that if you look at someone who's had an ACL injury, we all know clinically that we see that their quadriceps start to atrophy, they waste away, right? So the question is, why does that muscle waste away? What's going on there? Well, what they looked at is they looked at what they call quadriceps muscle endurance preoperatively, and they also looked at a clinical measurement that we all are involved with, those clinicians, is knee extension, right? So if you don't have full knee extension and you have poor quadriceps femoris muscle endurance, it predicts at 4 weeks why you have this muscle atrophy, okay? So keep that in mind. Loss of knee extension and the quadriceps femoris muscle endurance preoperatively predicts what your muscle atrophy is going to look like, or that loss of muscle at 4 weeks, right? So if you look at this clinically and we say, okay, well, I know that atrophy is related to the quadriceps muscle or quadriceps femoris muscle endurance, the ability to produce strength and muscle endurance, but it's also related to this knee extension deficit. So any of you guys who have worked with ACLs and you know that they have a 5 to 10 degree extension loss, then that is going to help predict that they just can't fully activate their quadriceps, right? So if we think about this, the authors, with their conclusions, they said that because of this, because they couldn't get their knee fully straight, that they were probably overloading after an ACLR. I would argue that we're not overloading, but we're actually underloading, because I'm walking on a 5 to 10 degree extension lag over and over and over for the first 12 weeks. I'm never fully loading that quadricep and activating it. And so what we'll see is that there's some changes because it can't fully fire like it needs to. So what we see is these new motor control strategies from the central nervous system they help to kind of transfer that load from the injured to the uninjured side. Yes?
Do you see the same strength deficits if you have a partial versus a full tear?
A partial versus a full tear. What do you mean by that, as far as?
Like, isn't there a case where you don't completely tear the ACL, but you only have a partial tear in the ACL?
Yes. Yeah. Okay. Yeah. Good question. So traditionally, what would happen with those is that if it's a partial tear and it's still functional, then there's the potential that they can rehab without surgery. Now, there's some debates whether or not that's actually the best thing. Oftentimes what will happen, though, if the knee is unstable and it's not functional, they'll go ahead and do an ACL reconstruction, so they'll reconstruct the whole thing. Now, it's a good question, because it does lead to one of our ongoing studies, is we're looking at ACL repairs, which is what you're talking about, and can you actually go in and just suture, if it is a partial tear, can you suture that up? And it's interesting, we'll talk about that a little bit more, but yes, that will change their outcomes dramatically because of all the trauma that goes on to the knee.
But do you still see the same strength declines?
No. Not nearly the same. Not nearly the same. And obviously there's something going on. It's always been hypothesized that all this trauma, we're drilling into the bone, into the tibia, into the femur. We're making these big tunnels. We're interrupting the overall homeostasis of the knee, and the knee does not like that. What we have seen, not only is it a strength thing, but it's also a motor cortex standpoint. It changes the way our brain reorganizes, just the whole pattern. And we'll talk a little bit more about that. Good question. So we shift really from the injured side to the uninjured side. Remember that picture that I showed you, the preoperatively, the girl that was at 0.85, same female, right? And this is representative of what we see across. Remember, preoperatively, she was 0.85 symmetry index. After 12 weeks of formal rehab, she's now down to 0.69. Not good, right? Right? So she's been through rehab, she's had surgery, her knee's more stable than it was, but now she doesn't load nearly as well. If you test her strength, she definitely has strength deficits, but that's not her whole issue, right? She can load it, she just doesn't know how. So she's got this reorganization of the brain that we don't fully understand yet, but it's this pattern where the body says, look, I'm not comfortable with this, I'm getting away from that limb, and I'm going to alter my strategy, okay? Now, at 12 weeks, what does their balance look like? What we see preoperatively, that they dramatically increase, so they significantly increase their balance, both on their involved limb and uninvolved limb. So at 12 weeks, their balance is getting better. Strength is still bad, though. Okay. This rock star right here, you guys may recognize her. She was a professional athlete with us that we trained, our model here. This particular study that we did a few years ago actually shows, looking at this balance stuff, is that if we can test their balance at 12 weeks in an anterior reach, and so they're standing on one limb and they reach with their other limb, if that number, side-to-side difference, is small, it predicts their performance on return to sport test at time of return to sport. So single hop for distance, triple hop for distance, and then also quadriceps strength as well. So meaning that the smaller that number is, side-to-side reach between my involved side and my uninvolved side, predicts that I'm going to do better at time of return to sport. Okay. Now, what about the loading at 12 weeks? Well, we've seen the same pattern. So this is the hip joint energy absorption contribution, hip joint for the uninvolved limb. And what we see is on that involved limb, they use more hip. Uninvolved limb, no differences. So greater hip strategy. At the knee, involved limb ACL group uses lower knee, and then uninvolved limb, no differences across the board. Okay, so the same pattern that we saw preoperatively. What does that mean if we look at it from a correlation standpoint? We saw with this particular paper weak negative correlation with the quadriceps strength of the involved limb and that involved hip energy absorption, meaning that I'm not strong enough here at my quads, so I'm going to use more hip. So there's this weak negative correlation that you see there. What's interesting, though, is that there's this positive correlation between the quadriceps strength on the involved limb and their ability to use that knee with energy absorption, meaning that the stronger my quads are, then the better my knee energy absorption is going to be. The better I'm going to be able to load on that particular limb, which kind of makes sense. So if we look at this, at that 3-month mark, increased energy absorption at the hip, decreased energy absorption at the knee, decreased quadriceps strength. So we've got this increased gluteal contribution with a decrease in contribution from the knee. The knee's saying, I'm not helping, I'm not strong enough, I'm not comfortable, I'm going to shift away from that. So it kind of gets away from the knee. Now, if we look across task, we see the exact same strategy. Across the task, this is in a single limb squat, energy absorption. This graph is kind of confusing because it looks like there's this big difference, but if you look at it statistically, 0.1 to 0.09, there's actually no statistically. That's for total energy absorption. That's when you don't look at the hip, knee, and ankle independently. When you look at it all together, it's misleading because it says, we're actually doing the same thing. When we go and we look at the individual joints, then that's when we see, again, on the involved side compared to the uninvolved side, greater hip contribution, okay, during a single limb squat, and then lesser knee contribution during a single limb squat. Same pattern, just different task. So the question then becomes clinically is that these individuals are at that 12-week mark. Typically, traditionally for the clinicians, you guys know that if they're 12 weeks after ACL reconstruction, between that 3 and 4 month mark, they're typically going to begin the return to running progression or their jogging progression. But the questions, if we have deficits at our knee, if we have, our balance is better, but if we still have these quad strength deficits, are they really ready to begin that return to jogging progression? Now, so this hints at that there's this foundational strength issue, but again, I would argue, are there also some neural issues or neural deficits that are in play? If you look at the literature, there's some good studies that actually suggest that there are, from a motor cortex standpoint, we see some deficits and some and decrease or some increased inhibition that actually takes place. So we see increased intercortical inhibition associated with the lower quadriceps voluntary activation, meaning that something is the brain telling me from the top down that things aren't right and I've reorganized the way I'm working. And then there's also some good brain activation with functional MRI that actually shows that following an ACL reconstruction, the brain does reorganize and it shifts from this sensory motor strategy. Remember, within your knee and in your ACL, you have these mechanoreceptors within the joint and the ACL. Those are all interrupted. So there's not this good afferent feedback. And so the body is really smart, and the body says, well, you know what? I'm just going to rely more on my visual motor strategy. And we see this a lot, these individuals that they don't have that good proprioceptive input anymore, so they rely on their vision. The problem with that is when they get back out on the court or on the field, they're running, they can't use that vision, rely on it. And so then when they have to go back and rely on their proprioceptive input, that's when they're more likely to have that tear. So we don't understand all this, but we know that there's some neural components to it. So that 12-week summary, again, our physicians, our rehab team are getting these reports, and they get to know where their particular patient is and what interventions they might need to start to work on or change around a little bit. Involved quadriceps strength deficits, involved, uninvolved, and healthy. 17% deficit from pre-op to 12 weeks, not good. That ratio hints at quadriceps strength deficits again. We're promoting this underloading of the ACLR limb, and I'll talk a little bit more about that. And then the Y balance test, those are starting to normalize, but we still see these same deficits in loading. And then we should probably question whether or not our individuals are ready to go back to their jogging. Okay. Again, they get this 12-week post-op report that shows what their quad strength is and then what their loading is. Okay. Now, finally, time to return to sport. Now we're actually doing a lot more dynamic activities. With this one, if we look at time to return to sport, we break it down into males and females. We still see these quadriceps strength deficits. So females 1.2 to 1.7, males 1.7 to 2.49. So still these pretty significant quadriceps strength deficits that are taking place. So asymmetries in strength may limit their ability to absorb on that involved limb, which we've seen all along that continuum. If you look at Y balance literature says, our literature says that they pretty much normalize. If you compare them to a matched healthy control group, you do see some small deficits in Y balance anterior reach, but the others kind of normalize. So balance overall is pretty good at the time of return to sport. If you look at different tasks, this is a presentation that one of our biomechanists did last year, and looked during a jump landing task in these adolescent males and females. What we saw is that the males and females use different strategies for energy absorption. So remember, what we've looked at previously is a squat, gait, and then also just a single leg squat. In this particular one, we look at a jump landing task, and what we see with the males is that they have decreased energy absorption at the knee. That's their strategy that they use compared to their uninvolved side. With the females, what they use is an increased energy absorption at the ankle, meaning that they're plantar flexing more and they're trying to accept that load through their plantar flexors, right? They still unload their knee, but they really use their ankle to try and compensate for that. Okay? And then in a paper we just put out earlier this year as well, and at a time return to sport, this is a energy absorption again, females across the board. We compare them to matched healthy controls. This is a little bit different task, and so this is a difficult one. They're jumping off one limb, landing on the other limb, and then they have to jump vertically and land again. So we're looking at their ability to absorb and load, but then to produce power. If we look at this in the lateral vertical jump, what we see is that in the ACL group, both on the involved and uninvolved limbs, they use greater hip strategy than the matched healthy controls, right? So same pattern that we see. The difference that we actually see in here is that the females that have on the involved side, they use less ankle contribution, meaning that they don't know how to load properly. So they're using greater hip, less knee, less ankle than the matched healthy controls. Okay? Now, if we look at their strength on that as well, if we look at the knee extension strength involved and uninvolved side, what we see bilaterally is that they're lower than the matched healthy controls. Okay, so they have deficits. I'm sorry, uninvolved side, they're not different. Involved side, they are different. If we also look more proximal, we look at the hip external rotation strength, we see bilaterally that they're decreased involved and uninvolved side with hip external rotation strength, which is a big controller, especially for this particular task, to control that femoral rotation. Okay? Now, busy graph, but let me just show you here what this looks like across. So if we put all this stuff together and we say, well, what does it mean across the continuum? What do they look like from a loading standpoint? If we look at pre-op, 12 weeks, and time to return to sport, I'll just kind of orient you real quick. The blue is the involved hip, right here, involved hip. Red, uninvolved hip. Green, involved knee. And then uninvolved knee is this purple up here. What we see, and we talked about this already, but what we see preoperatively is there's greater hip contribution, lesser knee contribution. And you see this at this time point preoperatively. What's concerning, though, is that we see when we get to this 12-week mark, we see even less knee contribution. It drops down, and see how this blue line goes up? The knee drops down, the hip goes up to make up for that contribution, right? If you look at this red and then this purple line, that's the uninvolved side, the hip and the knee. They stay pretty consistent across. There's some slight changes, but not a big change. They're pretty consistent across the board, okay? But what we see is at that 12-week mark, we see that these strategies really start to change, and especially at that 12-week mark. The involved limb utilizes greater hip than knee, especially at 12 weeks. And that to us is a little bit concerning as we see this. It goes down dramatically while the other one's going up to compensate. Okay? Now, what about in a single limb squat? We see patterns that are very similar. We see involved limb hip changes over time, uninvolved limb remain pretty consistent. So this is the involved limb, uninvolved limb, preoperative, 12 weeks, return to sport. Again, at that 12 weeks, remember that hip goes way up to compensate for that decrease in the knee. Okay? Same thing at the knee. What we see is that there's involved limb significantly decreased at 12 weeks. Uninvolved limb, which is the green, stays pretty consistent over time. Oops. Stays consistent. So see how that knee drops down. Remember, when the knee drops down, the body's smart. It's going to pick up that load, and the hip's going to take it on. Okay? So what does all this mean? Well, we take this and we give this report. So this is the report at time to return to sport, again, that our team's going to get. They're going to say, okay, balance looks good, strength still has these deficits, and then what does their loading look like? So we're going to look at the more static task of a single leg squat, double limb squat. We're going to use a drop jump landing, so we're going to look at that and their overall quality of movement and see. This particular individual, again, is a Division I football recruit, highly recruited kid, and he looks terrible all over the place, right? We look at their loading pattern. Are they loading symmetrically? Are they hiding that from us? And then we also look at this lateral hop vertical jump, which is a much more challenging task. And again, really strong kid, but he doesn't know how to use his strength very well, and he still has some deficits there. And then we look at this cutting procedure as well. So all of that matched up, then we decide, are they ready to go back to the sport? Okay? So that return to sport summary, we still see these strength deficits. We see the Y-balance test scores, their neuromuscular control is kind of normalized by this time. We see this deficits, we see the deficits in loading across double limb, single limb, jump landings, and lateral vertical jump. And so the question then is, are they really ready to go back to sport? So they've been 6.5, 7 months. Some of them are 8 or 9 months. And parents are eager for them to go back. Docs are eager for them to go back. The athlete's really eager for them to go back. But are they ready? So more often than not, what happens with us is we're making these decisions and recommendations to say, look, it's obviously your choice for your child and for them to go back, but they're not ready based upon these particular factors. Right? So the question then becomes, and this is where kind of some of our research is going with this, is do we really need to do more during those first 12 weeks? Because we're seeing this big change from pre-op to 12 weeks that are taking place. So from an intervention strategy, are we not doing enough? And then that comes into this point is, has this loading been sufficient for the athlete to return to the previous activity level? And so what I mean by that loading is, have we put enough pressure through that involved knee, or have we been too cautious with it early on? Now, what we've done is we've taken some of the European soccer literature that talks about loading, and we've kind of started applying that to our rehab. So just a brief overview of this. This is kind of taken, like I said, from European soccer literature that looks at training load. An example I would say is that I have, let's say I've got a soccer player that is a healthy soccer player that practices 2 times a week, okay, and then plays one game on the weekend. They practice for about an hour and a half, 2 times a week, so 3 hours, and then their game is 2 hours, right? So now we're at about 5 hours of loading throughout the week for their competition. What we would consider is that they are at a 100% loading capacity at their time before they've been injured, okay? Now, what happens after they've had this injury? They tear their ACL. Remember, they were at 100% loading, and now after their ACL, during those first couple of months, there's an argument that they're at 0%, but they may be at 5 to 10% loading. And the way we do this from a rehab standpoint is when they come in and they're exercising, then we've taken it from the European soccer literature, is that we developed this thing called a loading or an arbitrary units. We measure how long they've been exercising and then what was their rating of perceived exertion. And then we do that each time point from the time that they start therapy until the time that they go back. So what we look at is we look at this acute to chronic training or workload training ratio, right? And what that is over a 1 week period, that would be my acute load. And so if they went to therapy 2 times a week, they were in therapy and they exercised 45 minutes and their rating of perceived exertion was 7, then we would multiply that and we give it an arbitrary unit. And then the chronic piece is an average of the previous 4 weeks of that training load. If we see that this acute to chronic training workload ratio is greater than 1.5, then we know from an injury standpoint their risk goes up. Now that's in healthy individuals. If you look at our ACLs, they are way underloaded when you look at that acute to chronic training workload. Okay? So what happens is that most of our individuals that are going back at that time of return to sport, remember they were at 100%, by the time they're released to go back to sport, they're at about 35 to 40% tops. Okay? Now, society, parents, pressure, sports, all that, they've got sometimes 4 weeks to get up from a 35% training load to a 100% training load. And most of the time that doesn't even occur. So that is one of the things we've started looking at to say, are we rushing them back too quickly? So like I said, we have this training load study going on where we enroll these patients and we look at them first week post-op all the way during the first 12 weeks and then on out to the time of return to sport. We're measuring the acute to chronic training load. We're using a Fitbit to measure their steps, and then we're measuring what their overall activity level is. And then another piece of this, we're looking at an intervention study for blood flow restriction to say, can we make differences during those first 12 weeks by actually gaining some of that quad strength and that quad muscle definition back during the first 12 weeks. Still early on, but some of the things that we're looking at. And then kind of like you had mentioned earlier, this ACL repair versus reconstruction, we've got a study going on that's looking at someone who's had a repair versus a reconstruction. We don't see those big quad strength deficits, and the loading is much, much different. So that's what I have. Do we have some time for some questions?
Yep.
Okay.
Yep.